and grand rounds. Before I introduce today's speakers, I have some housekeeping items to review. This CME activity is jointly provided by the Queen's Medical Center and UH-JABSOM Department of Geriatric Medicine. As a reminder, evaluations are required for CMEs. You can find the evaluation form by following the link in the chat at the end of this talk, or in our email advertisement, or on our website. Your comments are very important to the planning committee and will be used to plan future programs. All speakers are asked about conflicts of interest, and these are disclosed on the title slide. Today's speakers have no conflicts of interest with commercial enterprises. It's my great pleasure to introduce our two speakers for today. Dr. Daniel Fischberg is the Medical Director for the Pain and Palliative Care Department at the Queen's Medical Center in Honolulu. He also serves as Professor and Chief of the Division of Palliative Medicine in our own Department of Geriatric Medicine at JABSOM. He holds board certification in internal medicine, pain medicine, addiction medicine, and hospice and palliative medicine, and is a fellow of the American Academy of Hospice and Palliative Medicine. As you can see, he's really an underachiever, isn't he? Dr. Fischberg is recognized as a national expert in the areas of enhancing pain and palliative care education for healthcare professionals, improving access to palliative care for patients at all stages of illness, and advancing evidence-based practice in palliative medicine. It was my great pleasure this past weekend to see him honored with the Mitz Aoki Award for community service, and he does provide a lot of service to our community. Our second speaker is Dr. Emma Grote. She is a board-certified hospice and palliative medicine physician who works at Navi in Hawaii. She enjoys the opportunity to educate patients and families about the many benefits of early palliative care. It's an honor for her to be part of the end-of-life journey for patients and families as part of the multidisciplinary hospice and palliative care team, providing comfort, guidance, and choice as they face end of life. And it's our honor to have both Daniel and Emma as our speakers today. Please take it away.
Thank you so much, Dr. Masaki. And boy, what a treat for me to get to start the year off by giving a talk with my very dear friend and colleague, Dr. Emma Grote. Emma and I are going to tag team this presentation. I'm going to start off by talking a little bit about the current context of medically hastened death, another term that's sometimes used as legally hastened death in North America. I've always felt that a really critical aspect of these conversations is always how to skillfully and compassionately respond to inquiries about medically hastened death, whether or not you plan to prescribe life-ending medication. And then Emma is going to do the second portion of the talk and talk specifically about Hawaii's Our Care, Our Choice Act and include some of her experiences as a provider in the community. As you've heard from Dr. Masaki, we have no financial conflicts to disclose. And again, just what this practice is called in the U.S., and I'm going to emphasize in the U.S., and we'll talk about Canada in a little bit. Death with dignity is an older term, but it still sometimes gets used because it's actually assigned to the laws in the state of Oregon and Washington. So it's officially the Death with Dignity Act in those states. But it's kind of fallen out of favor with both people who are supportive and not so supportive of the practice, acknowledging that that this practice is not the only way that people might retain dignity at the end of life. So it's kind of an older term, but it is still assigned to those state statutes. Physician-assisted suicide is an older term. It's still the term the American Medical Association, American College of Physicians feels is most specific and defines what this process is. A newer term that's come into use is medical aid in dying. Some people feel that the use of the word suicide has an association with mental health issues and an impulsivity that doesn't typically characterize the process for most people that are pursuing this. And then people looking at medical aid in dying say, well, that might be a little too euphemistic and doesn't really precisely talk about what the practice is. That's what the AMA and ACP have said in terms of their decision that PAS is the term that they're going to use. Another challenge is that medical aid in dying, when we start talking about Canada, it's very similar. It sounds very similar to their medical assistance in dying. They're both referred to as MAID, and yet the practices are very, very different in the US and Canada. Physician-assisted death is a term that the American Academy of Hospice and Palliative Medicine has used, but I'd say that that's becoming an antiquated term too, because a lot of the states have uh, their statutes have come to include other providers, physician assistants or advanced practice nurses to participate in it. So it's not only physician assisted at this time. Regardless of what it's called, in general, we're talking about the same practice. The provider, excuse me, writes a lethal prescription for a terminally ill patient who takes the medication in order to control the timing of their death. And very critically, it is not euthanasia in the United States. Euthanasia is the practice more where you have a beloved pet who might be at the end of life, and the veterinarian will do a lethal injection to bring about a hastened dying and avoid any further suffering for the pet. That's not the practice in the US, although we'll talk about it in Canada. This is the patient is voluntarily choosing to ingest this medication. So the national context, Oregon, Washington, Vermont, Colorado, California, Washington, D.C., and Montana all preceded Hawaii. It's not particularly common. Looking at the 2024 data from Hawaii, less than 0.5% of deaths in Hawaii used the Our Care, Our Choice Act. And historically, and I'm really basing this a lot on the data out of Oregon, which has had this practice the longest and has very granular and good data that's publicly available. About 1 in 3 people will actually obtain the medication, but choose not to ingest it. And I think a lot of people might understand that a major concern is having some sense of control over what's going to happen to you when you're facing the end of life. And sometimes just having that option available to you, that escape pod, if you will, is sufficient for 1 in 3 people who don't end up using the medication. Sort of a technicality, expense and availability of barbiturates in some recent years became a bit of an issue, leading to the development of some alternative regimens. Emma's probably going to talk a little bit more about that. But this is data, again, out of Oregon. And again, you can see it talks with death with dignity ingestions. Again, nobody really likes that term anymore. They're stuck with it because that's the name of their law. And this is just to show you that the barbiturates were sort of used on the left part of the graph. But when Our Care, Our Choice came to Hawaii, DDMP, digoxin, diazepam, morphine, propranolol was the regimen that was being used at that time. Shortly after that, it's changed to the propranolol changed to amitriptyline, and then more recently, phenobarbital has been added to that regimen, and you can see that's now the predominant cocktail that's used in Oregon and presumably elsewhere. So I think this is a current list. I actually just updated it a few minutes ago. These are the states, jurisdictions that currently have this practice, PAS, MAID, authorized in the U.S. My understanding is, Illinois and New York are the newest. They're just in the I think last month, their governors both signed bills that had gone through their legislature and will be enacted in later this coming year. Again, looking at the Oregon data, 2024, like any medical process, it's not without some complications. An 8% complication rate was reported in Oregon. Generally, that's difficulty ingesting, regurgitating, seizures. It's not the N is smaller because they only report it if there's a medical provider present, and you might understand that a lot of people may not have a medical provider present when they're ingesting. Time to unconsciousness and death, I've tried to provide that for you. Again, they have data for 250 individuals of time to unconsciousness. The median time was only 5 minutes. And I think if you track the data over the years, you can see why they've sort of settled on this new regimen. It does seem initially after the barbiturates weren't available that the times to unconsciousness and death were sort of trending upwards. But now more reliably, people are achieving unconsciousness and death in shorter periods of time. So the median time to death was less than an hour. And there's a range. 1 to 55 minutes to unconsciousness and 7 minutes to 26 hours. Regaining consciousness, nobody last year. There are a handful of people over the 20 plus years that have regained consciousness, but it's a rarity. Just because I wanted to show you some of the Hawaii data, it doesn't quite have the granularity of Oregon, and I've been looking at the Oregon data for so many years. I'm just more used to it, but I just wanted to provide it for you here. The number of prescriptions written, the number of known qualified patients who died, and then the number who died because they self-administered the aid in dying prescription. And you can see it seems like it peaked in 2023. And you can still see that the number of people who administer and die is substantially less than the number of people who get the prescriptions. You can't quite match it 1 to 1 because obviously somebody could get a prescription written in November and then choose to ingest in January. But again, certainly showing that the idea of getting the medication, finding it reassuring, and not choosing to ingest seems to occur here in Hawaii as elsewhere. I want to talk a little bit about Canada because it is so different, and just because I mentioned it's also referred to as MAID, but there it's medical assistance in dying instead of medical aid in dying. It does include the euthanasia option, which is essentially used 100% of the time, which I think people could understand why that might be preferable given the choice. It's a lethal injection. This is from the Health Ministry information. Midazolam, propofol, and rocuronium. I did italicize the rocuronium because those of us in palliative care might find that surprising. Rocuronium is a paralytic. It's a neuromuscular blocker. It's generally considered a contraindication to withdrawing a ventilator compassionately at end of life if the patient has neuromuscular blockers on board because they cannot manifest any distress. They can't grimace, they can't vocalize, they're paralyzed. They can't move at all. Presumably the midazolam and propofol provide adequate sedation, but in the intensive care units where we rarely have to do paralysis, we monitor EEGs very closely to ensure the depth of sedation. I don't find it reassuring knowing that EEG monitoring is not taking place typically in the bedside when this is happening. So that's just something that has always troubled me about the practice in Canada. It doesn't actually require terminal illness anymore. They use the term grievous and irremediable condition. In 2024, 5% of Canadians died using their medical assistance in dying. And that's, a little more than tenfold the rate that we see in the US. So that kind of has raised a lot of eyebrows. And there's also concerns because there is a intention for the medical condition solely mental illness, such as depression or substance use disorder, but grievous and irremediable could qualify people for medical assistance in dying, euthanasia. But because it's obviously very controversial, that keeps getting pushed off, and it's currently got a start date of March of next year. But again, just to make you aware, a very different practice in Canada than in the US. And people aren't entirely sure why things are so different. I found over the years that sometimes people outside the field of palliative medicine are kind of surprised that it's not the practice of medically hastened death is not universally embraced by palliative physicians. I think the palliative physicians are about as split on it as any other population. This is a position statement from the International Association for Hospice and Palliative Care that no country should legalize euthanasia, or PAS is the term they used, until universal access to quality palliative care is guaranteed. Euthanasia and PAS are distinct from palliative care. Palliative care aims to relieve suffering, not end life. Palliative care units and professionals should not oversee or administer euthanasia or PAS. And they point out what I'll be talking about is that requests for hastened death often stem from inadequate pain control, existential distress, or fear of being a burden, which palliative care attempts to address. So this is the part, if you were napping before through a lot of data and numbers, no problem at all. This is the time I might ask you to wake up just for a moment because I do feel this is at the heart of things about how do you respond when a patient is distressed enough to talk about wanting to hasten their death. So why do patients ask for medically hastened death? They may be asking for help. They may be very worried about their current suffering or fear of future suffering. There can be depression, which some studies show about a 50% rate of clinical depression in people expressing a desire for medically hastened death, or there could be physical symptoms, but I'll tell you that's least common. Okay, so this is the opportunity to hop onto the chat and try to answer a question. So which of the following is not among the top 5 reasons people request medical aid in dying or PAS? Inadequate pain control or concern about it, loss of autonomy, less able to engage in activities making life enjoyable, or loss of dignity. And I'm going to see if people want to put their answers in the chat, which is not among the top 5 reasons. So while I'm waiting, I'm going to toss out a dad joke. I threatened Emma I would do this. So Emma, did you hear about the 2 antennas that got married? The ceremony was so-so, but the reception was amazing. Okay, I see some votes for 1 and I see some votes for 3, mostly 1. And actually, yes, the answer is the majority weighed in. It is concerns about inadequate pain control, concern about are the least common. Thank you for those that replied. So this is, again, looking at the data from Oregon, the Death with Dignity Act data from Oregon. 2024 data is the most recent that's available. Loss of autonomy and less able to engage in activities making life enjoyable, that those typically are 1 and 2, but high up there also are loss of dignity, losing control over bodily functions, feeling a burden on family, friends, or caregivers, and inadequate pain control or concern about it, 34%, and then the financial implications, 9%. So I'm going to take some time now talking about the recommended response. And this actually comes from the Education in Palliative End of Life Care educational content, and they're big into these protocols. So the first protocol is clarify what is the patient asking you for. Are they just asking for reassurance, or are they really asking you for more? They're asking you to proceed with this process. Assess the underlying causes of the request, affirm your commitment to care for the patient, address the root causes of the request, educate the patient and discuss alternatives, and then consult with colleagues. So when a patient asks for hastened death, and this is something that Bill Breitbart, who's the chair of psychiatry and behavioral science at Sloan Kettering, he was the chief of psychiatry when I was a fellow. And what Dr. Breitbart would say to us is when a patient is asking the physician for hastened death, there are only 2 wrong answers. Yes, I will help you, and no, I won't. And what Dr. Breitbart meant was the patient does not need an immediate binary acceptance or rejection of their request. You don't want to shut down the conversation. Instead, what the patient needs is an immediate, non-judgmental, empathic response, a leaning into this great opportunity that the patient has given you to talk about what's at the heart of their concerns. Open-ended questions. Yes, of course, you do need to confirm, are they having suicidal thoughts or plans at that moment? But in general, this is people more concerned about the future and trying to plan. But of course, anytime a patient raises this, you do want to make sure there's not an active suicidal plan. And it's really important to be aware of your own personal biases. You might have strong feelings in favor or opposed to this practice, and you really need to check those at the door when you're trying to respond to the patient in front of you. Same thing about the potential for countertransference. You might have great positive countertransference, and seeing this patient suffer, you are suffering. You might have a less positive countertransference, and your motivations might be somewhat different. So some helpful responses have been, listed here. I often just want to clarify what's on their mind and what's prompting the query. Is it something that they're thinking about right now, or is it more that they're worried about something for the future? And could they just give me a sense of what are they thinking might make life not worth living? This is, I think, a time for us when we're assessing the underlying causes and asking the patient what's underlying causes to be mindful of what Dame Cicely Saunders, the founder of the modern hospice and palliative care movement, taught us about the four dimensions of suffering and total pain: the physical, psychological, social, spiritual, and existential. But from that data in Oregon about the major drivers of these requests, you definitely want to be focusing on mood and fears of the future. And this is a quote that often comes to mind to me. It's attributed to Mark Twain. I'm an old man and have known a great many troubles, but most of them never happened. And again, I think what to me, what this is talking about is that so much of our suffering is not in the present moment. And one of the great challenges of life, of course, is to stay in the present moment to minimize our suffering. Our suffering is generally when we're time traveling to the past with shame or regret, or to the future with worry and dread. And in these conversations about what people are worried about for their future, this can be helpful to be mindful and explore what is most concerning for the patient. So again, not to give the patient a yes or a no. You want to affirm your commitment. You want to listen, acknowledge feelings and fears. You want to reinforce that you want to continue to be the patient's physician, provider. You want to commit to help find solutions, and you want to explore options to allay their current concerns. You want to address the root causes of distress. If there is psychological suffering, you want to be sure you're treating depression, anxiety, delirium. Individual and group counseling have been shown in studies to modify the desire for hastened death. And of course, specialty referral for behavioral health services as you feel are appropriate. Focusing on these fears of loss of control are often really at the heart of these conversations. You want to explore areas for control and independence, or even that sense of control can be so important. And the patient's ability to determine their own medical care. In having these conversations over the years, I have not found a group of people who more are enthusiastic about doing their advance directives, completing their post form, knowing that there's a form that has essentially 100% chance of preventing them from the kinds of things they don't want to see happen in intensive care units at end of life. Again, you want to address these root causes, fears of pain. You want to talk about pain and symptom control. You want to, if appropriate, talk that sedation for refractory symptoms can be provided. No one should have to spend their final hours and days in pain. You want to provide a strong commitment to managing symptoms with yourself and, of course, a hospice team. Addressing fears of indignity is critical. Talking about what dignity means to the individual. Again, that sense of control. Of course, we never really have control over what's happening. Of course, in a serious illness situation, even less so, but that sense of control can be really important, and empowering patients to the ability that you can. Exploring resources to maintain dignity, and of course, reassuring the patient they're dignified in your eyes. That is not so much with things you say as in your entire manner of how you treat them. So Harvey Chachanoff has published a lot. He's a Canadian psychiatrist who's published quite a bit about logotherapy, dignity conserving care. These are some of the things I've taken from his publications in terms of how to empower people in dignity conserving care. How do they want to remember? What's still possible? I like this. What part of you is strongest right now? Uh, are there things that take your mind away from illness and offer you comfort? Are there things you still enjoy? Is there anything in the way you are treated that is undermining your sense of dignity? Just specifically calling that out and asking so you can try to address that. And again, this fear of abandonment can be very common. So you want to assure the physician, the providers, all of the care team will continue to be involved in care. And then you really want to emphasize the resources they're provided by hospice and palliative care. And we're so fortunate in Hawaii to have such robust community hospice and palliative care partners like Dr. Grote. Then you want to move on to education and discussing alternatives. Certainly if you've gone through all of this and the patient says, no, 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 thanks for all that, I really need to know more specifically about this, then you want to be giving them information about the law itself and what the process entails, but also information that they have other options, reminding them they can do their advance directives, refusing resuscitation and so on, withdrawing different treatments. Remember, The dialysis patient can stop dialysis anytime they want. Declining oral intake, voluntary stopping eating and drinking has been studied and actually can lead to hastened death as soon as or faster than going through the process of uh, medical aid in dying, physician-assisted suicide, and actually, surprisingly to some, I think that the quality of life measures through that process were not inferior. And then again, reassurance that if necessary, sedation for refractory symptoms at the end of life is always a legal, ethical, and professional option. So that is the education and palliative and end-of-life care recommended protocol, clarifying the request, assessing the underlying causes, affirming your commitment, addressing those root causes you've identified, education, and then consulting with colleagues. And as far as the consulting with colleagues, some resources. It's important that you have trusted colleagues and mentors you can talk to about this process. You want to be aware of the institutional policies and procedures where you practice. And of course, our hospice partners and palliative care community partners are the experts in this. They're social workers, they're chaplains, invaluable. And then just a couple final resources. The Department of Health website, uh, it talks about the Our Care, Our Choice Act. Mau has a lot of content on the website and links to the Department of Health. And then Compassion and Choices at compassionandchoices.org, always a good resource for information on the process. I'm going to now toss to Dr. Emma, who's going to take us through the second part of the talk.
Thank you, Daniel. Great. And thanks everyone for joining us today. I wanted to start with the story of a patient that I took care of on hospice services. His name was James, and he was a 64-year-old gentleman who was diagnosed with a thyroid cancer about 4 years before he moved to Hawaii. Despite many treatments, his disease progressed to stage 4. And when his oncologist gave him a prognosis of a year to a year and a half, he and his wife decided to move to Hawaii, where he felt his quality of life had really been the best it ever had been. He had actually met his wife 20 years previously when he was stationed in Hawaii at a bar in Waikiki, and they had fond memories of this place. They really felt close to the people here. They loved the friendship and the openness and the natural beauty, particularly the beaches, was something he really resonated with. I met him about 6 months after he had moved to Hawaii. He had just finished up palliative radiation to some metastases in his bone, and the palliative chemo he had been getting was causing him a lot of fatigue and weakness, so he had decided to stop that. On my first visit with him, I was really surprised at how fit he looked. Other than the cane beside him on the couch, I really would not have seen him as someone with stage 4 cancer. And in fact, his strength, his ability to be independent and a strong provider was something that he really resonated with and was very, very important to him. He brought up medical aid in dying on that first visit as something that he wanted to explore more. He was the primary caregiver for his mother during her last 8 months of life following a stroke. And during that time, she had been bedbound, totally dependent for all care. He felt that for him, being in such a state would not be something that had any quality of life. And he also worried that the burden that he had felt taking care of his mother would be too much to put onto his wife, as she was here without any other family support. While his wife was supportive of him doing this, she also made it very clear to him that she would be more than happy to be able to take care of him for his last days or weeks, however he happened to be. And he was pretty adamant, though, that no, that was not something that he wanted. He had come to us from Kaiser, and actually, Kaiser has a medical aid and dying team kind of embedded within their system. So it was easy enough to reach out to that team, collaborate with them, and they were able to support him through the MAID process. So fast forwarding about 5 months, he had been doing fairly well, was able to get to the beach 2 to 3 times a week, spend a couple of hours there, was still fairly independent with his ADLs, although getting a little more weak, and his energy levels were flagging. It was suddenly a lot more difficult for him to get up and down the 6 stairs of his apartment to get to the beach, and the week prior to my visit had been unable to get out at all. Um, I came to do a visit a weekend follow after a weekend when he'd actually fallen trying to get to the bathroom. And on my visit that day, he was too weak to even stand with even a two-person max assist. And he decided at that point that he was ready to take the MAID medication. However, there were two more things that he wanted to do before he did it. The first one was he wanted one more trip to Magic Island to watch the sunset and just enjoy the ocean with his wife. And the second request was to watch the big football game that I've forgotten the name of that was that weekend. I think the Super Bowl, that's what it was. The Kansas City Chiefs were playing, and that was his team, and he was going to see them win. And then Sunday, in celebration, he was going to take that medication. I called in the social worker who had actually worked very closely with his family, and she was able to arrange transportation for 2 days later for them to go to Magic Island and watch the sunset. And his wife actually took this picture as the sun was setting, and they both felt like it was a very good omen that if you look at the silhouette around the sun setting, it was kind of a heart shaped. And they both felt that this was a sign that their love was going to endure through all of this. Um, the trip took a lot out of him, though. The next day, he slept most of the day, and the following day, he had a significant change in status. He became delirious, unfortunately, very agitated. And when I went to visit with him, um, in discussing with his wife, we both realized he was unable to take the MAID medication. Um, and so we worked to keep him comfortable. We started him on some sedation to keep the agitation well managed. We had offered to transfer him to the Kailua home so that his wife wouldn't need to take care of him, but she really felt that that was an important part of this process for her. And we were able to get some resources in there to help her do that. And while he did not make it to the Super Bowl, I think it all went very well and probably better in a way for him as his team did not win. So I think he would have been a little bummed out about that. Um, but after he passed away, we were able to help support the wife as she finished up things here and then moved back to the mainland to be with the rest of her family. As Daniel had mentioned, there are many roads that people with serious illnesses take in their end of life treatments. The things in particular that I wanted to touch on was palliative sedation. As Daniel mentioned, that is something we will often offer to patients when they are bringing up medical aid in dying, particularly if the concern is pain or other physical symptoms. And what this does is it allows us to give patients medications that kind of sedate them over the last days to maybe a week of life, so that if the interventions we're using to alleviate some of these symptoms, most frequently things like delirium, anxiety, and shortness of breath, if our interventions are not working, we're able to sedate them to such a state that they are at least not aware of what is going on around them. Voluntary stopping of eating and drinking is something that I see more commonly than I would think in the era of medical aid and dying here in Hawaii. It offers patients in all 50 states the option of hastening their death by stopping of eating and drinking. There's none of the provider requirements that are required for medical aid in dying. There's no cost and expense related to the medications to actually take. Um, and like I said, it's legal in all 50 states. However, it is a bit more arduous for the patient undertaking it in that they have to be pretty resolute in the fact that they're not going to be eating or drinking. And often there's a lot of thirst and hunger during the first few days. And as people become dehydrated and organ systems start shutting down, you can have issues with pain, with anxiety and delirium, and also with reorienting patients that this was something that they wanted to do, and supporting family members through that process. Um, it can take about 1 to 3 weeks for a person to pass away after they stop eating and drinking. Usually it's about 10 days or so. So as Daniel was saying, when you look at the total time taken to actually going from request to having a patient pass, it's about the same as medical aid in dying, but again, a lot more intention and a lot more support needed by the patient from caregivers and families. In Hawaii, medical aid in dying has been legal since 2019. But because of difficulties with patients having access to providers, particularly on the outer islands, the changes were made to the law in 2023 that allowed APRNs as well as MDs to act as both the attending and consulting provider. There were also some changes made to the mental health piece, allowing psychiatric APRNs and marriage and family therapists to do that mental health evaluation. And the waiting period was shortened from 20 days to 5 days, which was more in line with the other states that have this type of law in place. And in cases where it was felt the patient may die within 5 days, that waiting period can actually be waived. So who is eligible here in Hawaii? Patients who are 18 years or older, who are residents here, who have that terminal prognosis with 6 months or less. They have to be able to make their own medical decisions, and they have to be able to self-administer that medication. I wanted to describe some of the provider components to this law. The attending provider is also the prescriber and kind of the person who is making sure that all of the necessary pieces are obtained and submitted to the Department of Health. Their role is to evaluate the patient, to do a more thorough assessment, as Dr. Fischberg has reviewed about why they are asking for this process, and to make sure that the patient understands all end-of-life options. They make sure, again, that all of the pieces are completed and submitted to the Department of Health, and they are actually going to be the ones who actually prescribe the medication as well. The consulting provider is someone, again, who will evaluate the patient, will agree with the assessment of capacity and the overall prognosis. We often find that a patient's specialist provider, either the oncologist or cardiologist, may be the prescriber. Sometimes the PCP can be a prescriber. But there are a fair number of cases where finding someone who can act as the attending physician is difficult. And we actually have some people in the community that we're able to refer these roles out to. The mental health providing role is actually unique to Hawaii law, and this is to ensure that the patient is capable of making the decision and does not appear to be suffering from an undertreatment of depression or another condition that could interfere with the patient's ability to make an informed decision. As far as the patient's role and things that they need to do, They have to make 2 oral requests to the attending provider, separated by a minimum of 5 days. And this verbal request has to be documented within the medical record by the attending provider. They need to sign 2 forms, both of which are on the Department of Health website. One is the written request that is signed by 2 witnesses. This one can sometimes be a little tricky when patients are getting weaker, more bedbound, and don't necessarily have a lot of people around them. As one of those witnesses has to be someone who is not family and who will not be benefiting from the estate. A patient's healthcare team member cannot be a witness, but through some of our local nonprofit collaborators, we have actually been able to find witnesses who are willing to come in and provide that service to patients that need it. And the witnesses are just attesting that the patient is of sound mind, they are not appearing coerced, and that they are acting voluntarily. And then the last thing patients need to fill out is the final attestation, which is completed no more than 48 hours prior to the ingestion. And that just acknowledges the terminal condition and the intent of the medications to hasten their death. I want to reiterate that medical aid in dying really is patient-driven, and patients can stop the process at any time. However, if patients are considering this as something that they want to have access to, I usually encourage them to finish up all of the steps until filling the prescription. Because often, if they come to a point where they really want to do it, trying to coordinate all of those visits, trying to have the patient have the energy that they need to finish the paperwork and interact with providers, it can be very difficult to do. There's nothing at all in the law about having patients share the plans with family, but in our team, we do our best to support patients, and if they need help with bringing the subject up to family members, we will help them in that. It's recommended, but not required, that patients have hospice enrollment, and not only for the support of the patient, but also for the support of the family should they go through with ingestion. Enrollment on a hospice can be very helpful. It's important that we respect a patient's wishes about what it's going to look like on that day of ingestion. And as patients on our service get closer to ingestion, both the clinical team as well as the social worker and chaplain will often work with the patient to find out what time they want to do it at, who they want to be there, is there special music or readings that they want done, so that we can really make it about them and have them go as it is that they want to. Again, healthcare professionals cannot administer the medication, and it's important for patients to know that the cause of death is the underlying terminal diagnosis. There's nothing about medical aid in dying on the death certificate at all, so that any life insurances that they have will not be affected by them using this option. Daniel mentioned the medications. This is kind of the standard one that we're using right now. Phenobarbital was made kind of standard of care maybe about 3 or 4 years ago, given the fact that it does allow patients to slip into unconsciousness sooner, as well as decrease the time until death. Here on Oahu, there's only 2 pharmacies that actually have the medication. The Kaiser Pharmacy for Kaiser patients fills it, and then there is a pharmacy over in Kailua that also mixes the medications and will ship them to outer islands if patients are needing them. There's a lot going on when patients or family members pick up the medication, getting education about how that looks, as well as medication safety. And that's something that our team goes in and reiterates after medications are obtained. Both Kaiser and ElixRx will actually take back medications that are not used, which is an important thing to know because you don't want this around the community. Again, self-administration must be done. So often when patients are getting closer to the date where they may ingest, we're going to have them practice swallowing 4 ounces of fluid within about a 2 to 3 minute period. And in patients who we know may be considering this, we remind them that you have to be able to swallow this so that if there is something that is going on, neurologic disease, or perhaps tumor compression that is making swallowing more difficult, we just bring that up to them and let them know that that is something they need to be aware of if it's something they still want to do. Rectal administration is an option. If patients have the strength to push down a syringe, they can actually administer the medication rectally. And we have had some patients with neuromuscular disease give it to themselves through a feeding tube, either again by pushing down on a syringe or by unclamping the tubing on a feeding tube. So after the medication is taken, usually patients will be sleepy and comatose within about 5 to 10 minutes. And that's why it's really important that they be able to take the medication within that 2 to 3 minute window. Once the medication is taking, it's not uncommon for patients to stop breathing for a short period and then start breathing again. But because the musculature is relaxed, sonorous, kind of snoring, gasping respirations are not unusual. And we make sure that family knows what's going to be happening before that happens. And if patients want hospice staff present at the time, we will also be there to help let them know what is going on and what is normal. So changes in respiration occur. Often people become cyanotic, change in color can occur, and the usual time of death is between 1 to 2 hours. There are some risk factors for a prolonged time until death, and these are important for the clinician to be aware of, not only in case medication adjustments are needed, but also so that they can let family know that time until death may not be in the order of 1 to 2 hours, but closer to 6, 7, 8 hours, just prolonged. In general, people who are younger, less than 55 years of age, may last a little bit longer, as well as those who have excellent physical capacity, who have great, strong hearts. Those are going to take a little bit more to peter out. People who are extremely obese may also require higher medications. Anything that leads to gut issues can be problematic as the rate of medication absorption is less. So people who have gastrointestinal cancers, people who are on high opioids and suffering from constipation, those who haven't really eaten or drinking for a while, can have some atrophy of the villi that absorb things, and it may take a little bit longer as well. I mentioned dysphagia, particularly as it worsens nearer to end of life, that can become an issue. Patients who are on high doses of benzodiazepines or opioids and those who have a history of drug use may also require doses that are slightly higher as well. And then keeping mental status in mind, particularly for patients who may have had issues with delirium in the past, because a patient needs to be able to be mentally aware at the time of ingestion to take it legally. And again, palliative care or hospice collaboration is highly recommended for so many reasons. Dr. Fischberg brought up Dame Celia Saunders and her concept of total pain. It's something we love in palliative care, and one reason why it's more than just a physician and a nurse. Her thought was in seeing people suffer near end of life, often as clinicians, we're just focused on the physical, but there is so much more underneath the water with psychological, spiritual, and social suffering. And if we are just throwing meds at physical pain, we are missing out on an opportunity to really, really make a difference for these patients and their family members. And I think that's where having hospice and palliative care involvement can be so important. First of all, it's not just the patient, but the patient and family. And as we saw so much of A patient's desire often to take these medications are loss of quality of life, worrying about being a burden, no longer enjoying things. So if we can bring the patient's family in there to help alleviate some of that, that can be a huge, huge benefit. And just by the fact that our palliative care teams have not only clinicians, but also the social workers and spiritual providers as part of that team can really help facilitate discussion and really make sure that patients and families feel supported. At Navien, when patients come on wanting to do medical aid in dying, or even who inquire about medical aid in dying, we have a special team that is there and that focuses on all of these aspects, and that will meet every week to kind of discuss if there's any other ways we can further support patients and their family members during that time. I wanted to end with a quick story about another gentleman. He was my second patient ever to take ingest medical aid in dying. Uh, his name was Will. He was a 72-year-old gentleman who had been diagnosed 6 years previously with colon cancer. He had had it resected, it was in remission, and then a year prior to me meeting him, he had had a recurrence. Despite another resection, despite chemotherapy, the disease had metastasized to stage 4. And he actually came onto hospice services with the medical aid in dying medication already prescribed and ready to use. On my initial visit with him, he greeted me at the door and then proceeded to take me on a 20-minute tour through his house, including this amazing, beautiful pond and gazebo, tranquility garden, he called it, where he liked to meditate, all the way up to a rooftop deck that overlooked the ocean with a beautiful mosaic that he had created. The house was exquisite. He loved to travel and had spent many years in Southeast Asia, where he picked up wood and cool doors and windows, and he had actually been able to work those into his home. He was a contractor and a builder, but a Renaissance man too. He was an artist, he was a musician, and was an integral part of the hula halau in his community, where he had played for so many years. And he was a mentor to many of the young people in his neighborhood, and he helped to teach them how to do construction and build. So on my visit with him, everything was tied up. He said, I'm going to know when it's time. I want to leave this earth still giving to it. So he really did not want any dependence at all. His main issues were some pain and then again fatigue. And as he was with us for a few months, pain started to increase a little bit more. And with the increase in pain medications, he was even more fatigued and unable to safely do house projects, getting up on ladders, things that he really wanted to do. He was no longer able to do them. And he decided at one point, okay, this is it. I've had enough. He had asked myself and the nurse to be there for the ingestion, and I can still put myself there. We were walking up the driveway, and we could hear some guitar music coming down from his bedroom window. When I got into the room, there he was, looking at some friends playing the guitar for him. He was dressed as a pirate. And we're talking complete with hat and the white shirt that was open at the neck and some crazy necklace. He had a treasure chest next to his bed. And it turned out he had spent that day kind of giving away objects to friends and family members that he felt was important, with blessings and love. And I thought that was, wow, just incredible. Um, so in his usual fashion, he had this beautiful glass from Thailand that he mixed the medication into. And as he took the medication, his friend was playing Aloha Oi, and he had his other friend dancing hula to that song. And after he finished taking the medication, he was even able to join in the song and just slowly fell to sleep and passed away about an hour later. And it was such a beautiful passing, and it was so in line with what he wanted. Um, it was wonderful about a month later to join his friends and community here at Waimanalo Beach to just celebrate the amazing life he had and just how wonderful for him to be able to exit while he was still giving to the community. So I think that is the one benefit that this definitely allows patients who so choose to have. Um, Again, some supports and resources, palliative care and hospice agencies can all be found on the Kokua Mau website. The Academy Aid in Dying of Medicine can be specifically helpful for clinicians who may have some ethical or more physical concerns. And then Hawaii End of Life Options is a newer nonprofit that we have here that works to support community around end of life and allow both patients and providers to have access to resources. So thank you all so much for joining us today. We
Thank
are
you so
open
much.
for
Thank you
any.
so much, Emma and Daniel, for an amazing presentation and some wonderful stories. We have about 5 minutes left for questions. If anybody would like to ask, okay, here's one from Seiji Yamada. Seiji, would you like to unmute and ask your question?
Sure. So, my question is, do all hospices in Hawaii offer medical aid in dying? And secondly, is palliative care consultation available for outpatients?
Yes, Daniel. I'll take the hospice question.
Yeah.
So um, there is a difference as far as how willing hospices are able to be involved in the process. There's actually federal legislation since this is not a since it's not recognized federally as a law, that Medicare funding cannot be used to provide any medical aid in dying services. So while no hospices are able to use their Medicare funding to do attending or consulting roles, um, at least at Navian and many of the other hospices, they will actually have specialized groups that are able to at least help patients navigate that system. And then some hospices will allow staff to be there at ingestion. Some do not allow that at all.
Yeah.
And as far as palliative care, outpatient palliative care, I know that Queens, you guys do oncology and cardiology now too. Is that right?
The oncology, but yeah, what I would say is I don't know of any hospices in Hawaii that do not provide care for patients who say this is something I plan to do. How much they're able to lean into it, I think varies. You know, the process that Emma described, you know, Navian really has a very specialized and formalized approach for how they support patients with it. I don't think that's probably, I think it's fair to say that's probably not consistent across every single hospice, but I don't think any hospice would say we don't care for people that want this. But again, the leaning into it is probably variable. As far as, you know, palliative care, I think that's something we're super excited about, that Hawaii literally is leading the nation in terms of access to community-based palliative care. Yeah, we've got a supportive oncology program that we're expanding here at Queens, but that's a drop in the bucket. You know, we have the first federally funded Medicaid community hospice program in the nation, the first of any of the states. So you know, it's really changed so dramatically. The only palliative care people could get when I first moved out here was end of life hospice care in the community. And that is not true anymore. It's everybody can get access to palliative care regardless of their payer now. And I would refer people to the Kukuamau website. It basically has a link. How do I get palliative care? And what island are you on? And people can self-refer.
Thank you.
Jeanette Coy-Jane has put a link in the chat about Kokoama, where to find palliative care in Hawaii. Thank you, Jeanette. Daniel and Susan, I'm sorry, Daniel and Emma, there are two questions related to the meds. Maybe I can expedite this because we only have a minute or two left. One is there a process of tracking the return of meds that are not used? And the second is, what is the cost of made medication which is not covered by Medicare?
The medication runs about $600. And I'm not sure if the medications that are returned are actually tracked.
Hmm.
I'm not sure about that.
Okay. Thank you.
It would, just for historical context, it was something we wanted to have in the legislature. We're talking about a 1,000-fold overdose of morphine. It's 15 grams, not 15 milligrams. And similarly to the other 100-fold overdoses of the others. So as Emma said, it's really something you don't want lying around, especially in a bereaved household. But I don't know that there's a formal process. It was great to learn today from you, Emma, that Elixir RX will take it back.
Thank you. John has put the link to the evaluation in the chat. So those of you who would like to get CME credits, don't forget to do the evaluations. We're out of time. There are several comments about the wonderful information and wonderful presentation that you both have given. Thank you so much again to Daniel and Emma, and thank you to our audience for your participation. We hope to see you again next month for another topic. Thank you. Bye.
Thank you.